Welcome to our webinar this evening. It is my great privilege and pleasure to introduce my very good and close friend, Dr. Joe Pizzimenti, who's going to be talking about our top topical and ocular medications. I worked with Joe for many years at Nova Southeastern University's College of Optometry, where we saw patients together, we taught courses together, and he left to move to the University of the Incarnate Word, Rosenberg School of Optometry in Texas, where he is a tenured professor. Joe Pizzimenti is an internationally renowned lecturer and author. He has been involved in the forefront of optometry, being involved in many organizations, past president of the Optometric Retina Society, numerous chair positions within the academy, and has authored many articles, has mentored many students, taught many students. He has been instrumental in the residency program at Rosenberg School of Optometry, and he really is one of the Renaissance people in optometry. I don't think we can find anybody who has an ill thought or cross word for Dr. Pizzimenti. He is really a person that gives me faith in humanity. So with that, it's my great privilege and pleasure, and your great privilege and pleasure, to see and hear Dr. Joseph Pizzimenti.
Well, thank you for that wonderful introduction. Joe Cequa, you are too kind, and I want to thank you as well as Dr. Greg Caldwell and of course Vanessa for doing such a wonderful job with these conferences at OEC, both live in person and now online. So we're going to sit back and hopefully have a nice, easy couple of hours of continuing education with some interaction, audience polls, and Q&A. And so if you notice it says our top topical ocular meds, I have to acknowledge my writing partner, Carlo Polino, and he and I do this lecture. It's a 3-hour course together. And the handout that you have is actually for our 3-hour course. And I did that on purpose. We're not going to get to all the slides tonight, but I want you to have the additional information as a reference. Of course, if we don't get to your question tonight, here is my email at the University of the Incarnate Word. And we are in San Antonio, Texas. So let's, without further ado, move on to my financial disclosures. I've received honoraria from a couple of publications and have some scientific advisory board appointments. I've received consulting fees from a few companies. And as Greg mentioned, there will be opportunities for you to submit questions throughout the webinar, and every 25 to 30 slides, we'll briefly pause and take those questions. But first, a statement about what pharmacotherapy has meant to our profession and to our patients. The ability to use pharmaceutical agents has enabled optometrists to become true primary healthcare providers. And it all started back in 1976. The battle to gain prescription rights was first won by optometrists in West Virginia. And here we are many decades later, and our patients are certainly benefiting from it. Our profession has benefited from it. And the good part about pharmacotherapy, whether it's topical meds, orally administered meds, injectable meds, have you, is that this does not need to come at the expense of what some would call traditional optometry. Optometrists are out there providing excellent refractive care, specialty contact lens design, low vision rehabilitation, pediatrics, sports vision, you name it. So it really has broadened our scope and what we can offer. So our goal over the next 100 minutes or so is to provide current and accurate information about key topical drugs that are used to treat eye diseases. And we'll be using case examples like this infectious keratitis that you see right here, as well as topical discussion. And so the pun is intended since this is a topical meds course. As you know, we can administer medications by various routes, but really optometry really got started in ocular therapeutics with the use of topical dilating agents and then topical therapeutic agents. Just a word about installation of medications. Proper technique can significantly increase efficacy, and improper installation of drops, ointments, suspensions can reduce its efficacy. We could be the greatest clinician in optometry, but if the patient can't get the drug into the eye, then they're not going to get better, at least not the way we want them to. So there should be people in our offices that are well trained, that can sit with the patient and don't let them leave the office until they have demonstrated some degree of ability to instill medications properly. And we're not going to teach anyone how to write an Rx here. Uh, we've all been prescribing for years and years. I did want to make mention briefly about e-prescribing, so I put this extra slide in. You know, over the past decade or 15 years or so, it has demonstrated to be secure, easy, it saves time, it helps us avoid medication error. You know, usually the prescription form has a nice user interface where you have the type of prescription, whether it's a new Rx or a refill Rx, the medication name, the dosage, and then the SIG or instructions for the medication, the quantity, number of refills, and so forth. And I think the American Optometric Association and the state associations all have great resources on e-prescribing if you're not yet involved in that. A brief review of some of the main principles of pharmacology. Pharmacokinetics describes what the body does to the drug once it enters the system, whereas pharmacodynamics refers to how the drug acts upon various tissues in the body. So we must always be mindful of contraindications, side effects, and drug interactions before recommending a course of pharmacotherapy. So every time we write a prescription, really anytime we recommend a treatment for a patient, whether it's LASIK or whether it's topical steroid, an IOP lowering med, an oral med, panretinal photocoagulation, we always have to take into account the risk benefit ratio. And so suffice to say that the potential benefit of a treatment or a drug needs to greatly outweigh any risk that that treatment poses to the patient, or in some cases, the patient's child or fetus. So we keep in mind things like the age and weight of the patient. And there's an old rule in medicine that you'll find in some old medical texts. Consider starting with 1/2 the regular adult dose in the young or in the elderly. And this applies primarily to oral medications. The elderly, as we know, are often on multiple meds, multiple eye meds, and this may lead to adverse reactions as well as interactions. So know your patient. You know, we usually have a pretty good profile based on the patient questionnaire and based on the patient history. We need to have a thorough medical history in terms of medications that the patient is taking, as well as allergies. Realizing that each and every patient is unique with their own set of health conditions and their own set of personalities, right? Their fears, their concerns. You know, we really need to treat them as individuals as best we can, individualizing their therapy. So in choosing the proper drug therapy, there are certain considerations that we need to look at. And one of them, especially nowadays, is the viability of that person's immune system, in particular their kidney and their liver function. Is the patient pregnant? Are they nursing? How old or young is the patient? and what is their allergy history. Each drug has its own individual safety profile as well. Now, fortunately, we have all kinds of apps and online databases. We used to have the big thick PDR, and then there's another text out there, ophthalmic drug facts and comparisons. So fortunately, we don't have to memorize all of this, although we should have a general idea of potential safety issues, side effects, contraindications for various drugs and drug classes. How effective is the drug, especially antibiotics? And then there's cost considerations. And remember that cost does not necessarily refer to the price tag on that bottle or tube of bacitracin, whatever the case may be. If we are using an inferior medication or one that is not as effective as another med, we may end up prolonging that patient's condition and they end up paying more in office visit fees. And so cost to that patient isn't just the price tag. Most drugs are metabolized by enzymes that reside in the liver, produced by the liver, whereas the kidney is the major route of drug excretion. Now, some drugs are excreted after being metabolized, whereas others are excreted in a form that is relatively unchanged. So, proper liver function is critical for metabolism of even topical medications, and kidney function is essential to drug elimination or excretion. Topical meds, remember, are absorbed directly into the bloodstream via the conjunctival and episcleral vessels. So they are not broken down by the GI tract or by the liver. When prescribing for pediatric patients, even topical meds, I've gotten into the habit of placing a courtesy call and sending a follow-up note to the pediatrician, letting them know that their patient has successfully been treated for, whatever the case may be, a viral conjunctivitis or ocular allergy, whatever the case is, especially with oral meds, but also with topical meds. And this is a practice builder because, most pediatricians do not have a slit lamp. Most of them don't feel terribly comfortable dealing with certain types of red eyes and ocular conditions. And so maybe they'll remember that note that I sent them or that you send them, and the fact that, hey, this optometrist down the road is a good egg. They keep me aware of what's going on with my patient. I think this red eye that I have here, I don't want to deal with it. I think I may send it over to Dr. So-and-so. Now, fortunately, there are some programs out there to help with patient access to the medications that we want to prescribe, patient assistant programs. Most of the major drug manufacturers, especially those that produce medicines for glaucoma, have rebate programs. And so there are forms we can enroll patients into these programs if you want to prescribe a certain brand medicine. Of course, goodrx.com, I think most people are familiar. You can plug in the zip code and the drug that you want, and it will give you all kinds of options from brand names to generics, and sort of scan the local pharmacies to see where where the coupons may be. And then there are lower priced options that we sometimes resort to that are still very effective. A drug like Polytrim, for instance, polymyxin B and trimethoprim solution works very well. Maxitrol, again, yeah, you're dealing with neomycin, so there's always the possibility of toxicity. And I prescribe Maxitrol liberally, and probably once a year I'll have a patient that does, end up coming back with an allergic reaction. But for the most part, this is an inexpensive, effective medication in certain types of cases where there is inflammation with the possibility of bacterial infection as well. Oral acyclovir remains the most cost-effective systemic antiviral medication. Prednisolone sodium phosphate, 1%. This is a solution. It requires no shaking. It's available generically, and I use it all the time. All right. Now we have generic prostaglandin analogs. We have alpha agonists. We have beta blockers for glaucoma. And so these programs that are out there, including RX Assist and Needy Meds and programs like that, really can be a boon to our patients that need a little bit of assistance. Now, I remember this patient vividly. We were in, I don't know if it was North Miami Beach, way back in the day with Joe Sauka. And this was a Jamaican woman, and she came in with a unilateral posterior subcapsular cataract, unilateral glaucoma. It turns out that she was using a topical steroid ointment, hydrocortisone on her eyelid in one eye for atopic contact dermatitis. And I asked her, how often do you use it? She says, oh, I use it every day. And how long have you been using it? Oh, about 3 years. So even though this is a topical steroid and it was being used on the lids, that transdermal absorption resulted in high IOP, glaucoma, as well as unilateral PSC. So we don't tend to think of topical medications as having real significant side effects, but they can have local side effects if used often enough and for a long enough time period. Systemic side effects of topical medications. So we must remember that the eye does not exist in isolation. Every pair of eyes that we've seen in our career had a whole person attached to them, right? So all topical agents should be viewed as potentially systemically active, systemically potent. And to avoid systemic side effects, be aware of the patient's medical history, including their current medications, but also any vitamins, herbs, and supplements that the patient is using, because these can act just like drugs, right? Especially in certain doses. Prescribe the appropriate drug at the appropriate concentration and appropriate dosing schedule to avoid systemic side effects, and have the patient tilt their head back, close their eyes, and perform digital punctal occlusion for about a minute or so, keeping the drug in the ocular tissues. So here's a case. This is a 38-year-old female complaining of painful blur in the right eye over a 2-day period. She's complaining of redness and tearing as well. And so obviously not a trick case, right? None of the cases that I'm presenting tonight are really trick cases. They're rather representative of bread and butter optometry. So dendritic ulcer, herpes simplex viral, keratitis, and there are certain topical medications that are approved and lend themselves nicely to the treatment of a dendritic ulcer. Traditional topical antiviral treatment was with trifluridine, 1%, right? Commercially available as Viroptic. It works. There's some collateral damage in the form of some corneal toxicity, but the goal is to eradicate the virus, and trifluridine has been out there for decades. It's tried and true. A more contemporary topical antiviral treatment with some advantages is ganciclovir ophthalmic gel, right? So this is a gel, 0.15%, and it is commercially available as Zergan. And by now, it's been out a couple of decades, I believe, and just about all of us have prescribed Zergan for herpes simplex keratitis. It targets the replication of viral DNA in infected cells only. So it has a much lower propensity to cause corneal toxicity when compared to the earlier generation trifluridine. It is categorized in the old pregnancy scale as category C, which puts it in kind of a moderate risk category, but we'll get into that a little bit more later. The drug is approved for those age 2 and older, and there's your dosing schedule for Zergan: 1 drop 5 times per day until the dendrite resolves, and then 1 drop 3 times a day for 7 days after that epidefect is resolved. Here's a 25-year-old female, 10 weeks pregnant. All right, so that's a different wrinkle now. Again, another dendritic ulcer, can't miss it. And so special populations like pregnant patients deserve special prescribing considerations. And so here's a little more magnification on that beautiful dendrite, right? Pregnancy category B carries a lower risk than pregnancy category C. And in this particular case, I actually got on the phone with the patient's OBGYN, let them know that there's this new drug out there called Zergan. It appears to be quite effective. It's considered category C. Acyclovir is category B. And I wanted some input from their OBGYN. Certainly, acyclovir on paper would be maybe the safer option, at least according to the rating system. And that's where the OBGYN wanted to go, without telling me that that's what we need to do. I could tell that's the direction that they were leaning in, and I didn't disagree, right? So acyclovir, oral medication, and we prescribe this all the time. It's it's low cost. It's effective for acute infection, 400 milligrams by mouth 5 times a day for 7 days, effective against dendritic ulcers. And if you catch it early, patients with herpes simplex blepharodermatitis, the breakout on the lids, a vesicular eruption, if you catch that on day 1 or day 2, sometimes oral acyclovir can heal that rapidly. And so these are the older traditional FDA use in pregnancy ratings, where category A drugs were said to be absolutely safe. Category B, probably safe because there was no evidence of risk in humans or adverse findings in animals. Category C drugs were considered questionably safe. Their risk to the fetus cannot be completely ruled out, but the potential benefits may outweigh the potential risk. And so, most likely, no harm would have come to the fetus had we prescribed topical Zergan instead of oral acyclovir, but they were in different categories. We avoid drugs in category D and category X in pregnant and nursing patients. And that was a good system. It was a simple system, but perhaps the FDA thought it was oversimplified because it kind of did away with that system. So Zergan, a pregnancy category C drug, topically. So this goes back to the end of 2015 or so, when the older labeling was changed, right? So what they did was to combine 8.1 and 8.2 and call that the new 8.1, pregnancy including labor and delivery. The old 8.3 becomes the new 8.2, lactation, including nursing mothers, and then a new category, 8.3, females and males of reproductive potential. And now, instead of getting an A, B, C, D rating, we get a narrative. So it's more information for us to sift through, but it is more information to look at in making your recommendations to the patient. And for now, what I'm going to do is to give a chance to do some Q&A.
Only if you tell us, did you take that picture and where is it?
This is not my picture, but this is actually Turin, in northern Italy, Piedmont. Actually, this is a different version of the presentation, Greg. It's not terribly different, but I could try to pull up the more recent version if you want while we're taking questions, or we could just leave this one up if it's working
Whatever,
just fine for you.
whatever you want to do. The only
I'll see
question,
if, yeah.
the only question that has come in so far, Pizzy, is using oral antiviral for simplex, half the dose as used for zoster, question mark. And I can,
That's correct. Zoster, you double the dose. That's right.
Yeah. And from my standpoint, and that, pharmacies never always, you can say agreeable. I go with full strength whenever I treat zoster in the clinic, because my impression is that their viral load, they're immunocompromised. It's an extremely safe medication. So
Oh yeah.
I just remember 800 milligrams 5 times a day if I'm going to do acyclovir, or 1,000 Valtrex, simplex, or zoster. I don't think there's a right or wrong answer. If you want to go with a lower dose for simplex, it's definitely the wimpier one that's out there. So
yeah, and it is a relatively safe medication. And I find myself more and more just going right to the oral medication for herpes simplex keratitis. It's nice to have a couple of topical alternatives, knowing that not all states have oral antivirals for optometry, especially the option of Zergan is certainly preferable to trifluridine. It's effective. Let's see if I could pull up the more recent version.
while you do that,
Yeah.
there's another question that has rolled in.
Yeah, go right ahead.
That says, everyone seems to use Valtrex as opposed to acyclovir. What do you think? And
I think it's a better dosing schedule, probably more bioavailable. In terms of cost though, and both are available generically now. So so I think they're relatively equivalent. Certainly the dosing schedule is more convenient. So that's where I think the advantage is for some of the newer generation meds.
Yeah, the biggest difference that's out there between acyclovir and Valtrex is that Valtrex is the only one that is lactose free. So
Oh, that's an important consideration in many patients, right?
Yeah. So between the three that are out there, if you're, there was a lot of GI issues with in the head study 1 and 2. So generic and branded Valtrex is lactose free for you guys that are out there.
And no question. And if the patient has an excellent, drug plan and is easily able to pay for either generic or brand Valtrex, it's certainly the preferred antiviral for those cases. I think we're ready for a polling question, yeah?
Yeah, I think so. Once you get your slides back up, and
I think I do. Could you see them?
No, now they are coming up now, it looks like. There is another kind of comment while you're switching over there, and it says there's no blood vessels in the cornea, so topical is more effective. Yeah, anytime you can apply medication topically, you're definitely going to get a better mechanism of action.
You're getting right to the site of involvement. Now I'm seeing, I think I might be seeing someone else's screen at this point. So
you might want to try sharing something else there.
Yeah, I'm going to try again.
And then it says Zergan is very expensive and hard to find. And as you're doing that, I'll make the comment that I usually work with my local pharmacist, and there's a few medications I always like for them, at least a local pharmacist, like a mom and pop that's right down the street. I have them keep atropine 1% in stock, and I ask them to keep a bottle of Zergan. I always use the patient's pharmacy that I want them to use, but if I have someone coming in with a smoking iritis, I want to use atropine, then at least I know there's a bottle in play somewhere, and that it's not that 48 hours or 24 hours where they get it from the laboratory or from the warehouse. And the same thing with Zergan. And I agree, it is expensive. So
let's
all right,
see.
Joe, you're still not sharing.
Well, I'm going to try again. Let's try this one.
Nothing yet. I'm going to launch the polling question while you're doing that. The
Okay.
polling question is going to be, what is the current mainstay for the initial treatment of anterior uveitis? NSAID, antihistamines, antibiotics, corticosteroids. And I think everyone is just quickly weighing in on this. There you go.
So now I should be sharing my screen, yes?
Yep, you are. You've
You are.
got the correct polling question. I'm going to end this polling question because everyone has pretty much nailed it. We have a handful that have said NSAID and antihistamine, and 96% have said corticosteroid there, Dr. Pizzimenti.
Yes, indeed, the vast majority. So let's move forward with the next poll question. Again, these aren't here to trip anybody up, but just to make sure that you're there and hopefully keep folks engaged.
So which of the following adverse effects is most likely to occur with a patient on an oral prednisolone?
So weight gain, retinal detachment, weight loss, or meiosis?
And we got a well warmed up crowd here tonight. Dr. Pizzimenti, you can't see it on your end, but we'd like for them to get about 90%, and everyone's warmed up here and up to about 81%. So they're doing great here.
Oh, great.
Yeah. Part of the live and interactive education. So, and with that being said, I'm going to end this poll. And I'll share the results so you can see them, I believe, once I do that. Share results.
Yep, weight gain, overwhelmingly the number one answer, the correct answer. Well done for a Sunday night. And here's a nice picture of Scottsdale, Arizona. And another reminder to feel free to type in your questions as we go. And I'll be taking breaks. So this is the case we just reviewed, right? And there's your ganciclovir. Now that I have the correct version of the presentation, there's your dosing on acyclovir, 400 milligrams, 5 times a day for 7 days. And yeah, you're more or less doubling the dose for zoster. The pregnancy ratings. And so this is a conversation that we like to have with residents or students before clinic. You know, if you had a dozen topical drugs, to cover everything that you're going to see in practice, what drugs would you choose? And it's really more about what classes of drugs would you choose, but we all have our favorites. And so my list changes every year. It's probably changed already. So in no particular order, here we go. My go-to topicals, tobramycin, 0.3%, old school aminoglycoside, broad spectrum. Has an FDA indication for bacterial keratitis. Alcaftadine, commercially available as Lasticaft, a once-a-day antihistamine and mast cell stabilizing agent for those patients with ocular allergy. Again, you'll have your favorite drug in that class as well. Travoprost Z, an IOP-lowering medication, prostaglandin analog, 0.004%. Levobunolol, all right, so a topical beta blocker, and I'm still a creature of habit and used levobunolol as a primary therapy, a first-line therapy for many years before the prostaglandins came out, and it's still nice to have a drug like Levo 0.25% or 0.5% available. Do you like Timoptic better? Do you like Timoptic XE? That's fine. All beta blockers, all right? We know what they do. We know what they don't do. I'm going to throw in a few oral medications, even though this is a topical lecture, because we're talking about all-purpose meds, and doxycycline and minocycline have many, many uses in eye care. And if I had to pick one antiviral because of cost and efficacy, I would go with acyclovir. And then oral prednisone, because nothing fights inflammation like a steroid. What else is on my list? Prednisolone acetate, 1% suspension, Commercially available is Predforte. We're all very comfortable using this drug for uveitis and nodular episcleritis. But I also like to have prednisolone sodium phosphate, 1% solution. You don't have to shake it. Is it quite as good efficacy-wise as Predforte, name brand Predforte? Maybe not, but for many patients, it is more than adequate. Bromfenac, 0.09%, a topical nonsteroidal agent, commercially available as Bromday. It's available generically now, I believe, and this is for primarily post-surgical care, patients with postoperative cystoid macular edema and the like. A combination steroid antibiotic, right? Tobramycin 0.3% with dexamethasone, either in 0.1% or 0.05%, depending on which version of the drug commercially available as Tobradex or Tobradex ST with the 0.05%. So steroids first, really, they act like steroids, but they also have some antibiotic qualities as well, right? So for inflammation where there's concurrent risk of bacterial infection, some of the most widely prescribed drugs in optometry are these combinations. Cyclosporin, again, this drug also comes in 2 formulations and 2 concentrations, 0.05% or 0.09%. So this is for aqueous deficient dry eye disease, ocular surface inflammation. So we've become very comfortable with cyclosporin over the years, and so have our patients. Topical 4th generation fluoroquinolone antibiotic, moxifloxacin, 0.5%, commercially available as Moxiza, approved for bacterial conjunctivitis, but also lends itself nicely to bacterial keratitis, although realize you are using it off-label for bacterial keratitis. And so, and I'll put that list back up in a minute, but the majority of red eyes that present to us are primarily inflammatory or allergic in nature, right? And in immunocompetent patients, most red eyes will get better if we do absolutely nothing, right? So at first, above all, do no harm, right? So we want to help the body's immune system fight off whatever is causing the inflammation or allergy. And I think this list kind of reflects that. I've put in yellow font those medications that fight inflammation, that are appropriate for ocular allergy. Even cyclosporin is an immunomodulator, and so it has immunomodulatory, anti-inflammatory properties. Again, the vast majority of red eyes are inflammatory, not infectious. Of course, we still do see our cases of bacterial keratitis and bacterial conjunctivitis, but for every, corneal ulcer that I see, bacterial ulcer, I'll see at least 50 to 100, viral conjunctivitis or allergic disease. So there's the list, and of course, you're going to have your own list, and it'll be different than mine. We gravitate to what seems to work for us. A couple of newer medications. This one's been out for a little bit. It's cyclosporin ophthalmic solution, 0.09%, commercially available as Cequa. This is the highest FDA-approved concentration of cyclosporin. It is in solution form, so it's not an emulsion. BID dosing. NCell technology uses nanomicelles, and these are made of polymers that wrap around the cyclosporin molecule. And this drug has shown good efficacy and safety, certainly in its clinical trials before it was brought to market, and now as another medication in our ocular surface inflammatory disease toolbox. I'm sure many of you have also prescribed Lifitegrast, commercially available as Xiidra. And this slide shows the value of lissamine green staining. Remember, the ocular surface includes not only the cornea, but the conjunctiva as well. And so, yeah, Rose Bengal will do more or less the same thing. It's going to sting a little bit more than lissamine green, but lissamine green does a tremendous job of identifying areas, especially on the conjunctiva, of surface dryness. And this drug, Lifitegrast, binds to the integrin lymphocyte function associated antigen 1, or LFA1. Now, this is a protein found on the surface of white blood cells, leukocytes. And the drug blocks the interaction of LFA1 with ICAM1. These are intracellular adhesion molecules. And ICAM is upregulated and overexpressed in corneal and conjunctival tissues in aqueous deficient dry eye disease. And so I know many of you have prescribed these last couple of drugs, newer dry eye medications, as have I, with some success. So what's in your dozen, right? It's not so much about the individual agents, it's more about the different classes of drugs. You know, where are you geographically? What types of ocular infection and inflammation are you seeing in the Northeast or in the Southwest? You know, in the in the Pacific Northwest. So you're going to come up with your own list, no doubt. Can we do another poll, Greg? Here we are. Clinical sign that is a hallmark of herpes simplex keratitis. I think you could all see the choices: dendritic ulcer, marginal infiltrate, microcystic edema, punctal corneal staining. Please submit your response.
And Pizzy, as this is rolling in, there's a question that rolled in regarding doxycycline. Comes in hyclate and monohydrate, I believe is what it is. They have mono written in there. And the question is, which one?
Yeah, I mean, it's whatever I could get my hands on. And sometimes that means, going to minocycline instead of doxycycline. Again, I find that they're more or less clinically equivalent, and it depends on what condition you're looking to treat. If it's meibomian gland dysfunction, there are some studies, including one done by Bascom Palmer several years ago, showing that lower doses of doxycycline, you don't necessarily have to prescribe, 200 milligrams twice a day. You can get by with maybe 50 milligrams once a day, along with lid hygiene and maybe even some omega-3 fish oil, and reduce the likelihood of side effects. But I know that in certain parts of the country, it's harder to get certain forms of doxy than other forms, as well as minocycline. Sometimes I'll be able to get minocycline, but not doxycycline. And, they're relatively equivalent, all in the tetracycline family of drugs.
Yeah. And to add to that, to everyone out there, is that, I always use when we do this talk, and I deal with a pharmacist from time to time, and that comes up. And I usually use the analogy. It's kind of, the doxycycline is what you want to deliver. The hyclate and the monohydrate is the delivery system. So usually what I tell the audience is, some people like vodka, some people like it in orange juice, some people like it in cranberry juice. It's still the vodka that the people want. So it's really the doxycycline. So whether it's the hyclate or the monohydrate, it's just a delivery system.
Well, what if you drink scotch?
Well, there you go.
Just kidding, Greg. Just kidding with you.
Joey, a question came in that I'm going to answer for you, because I wouldn't expect you to specifically know this, because this is Florida. And the question is, for what length of time can we prescribe oral steroids in Florida? Now, in Florida, pain medicines and oral carbonic anhydrase inhibitors have a 72-hour limit. We don't have any oral steroids in Florida. For the person who asked that question, that is not on our oral formulary, so we don't have any oral steroids in Florida at this time.
So if you have a case that you really think needs a systemic steroid, probably best to co-manage that one, right?
Yes. Question came in, why Tobradex over Maxitrol?
I like Maxitrol just as well. And, I probably prescribe more Maxitrol nowadays than I do, the brand name Tobradex ST, simply because of economics. Although Tobradex has now gone generic as well. So, yeah, again, you're looking at combination medications. They all work to some degree. Maxitrol does carry the higher risk of toxicity to the cornea.
Joe, I have found that in terms of price consistency and low cost, Maxitrol is more consistent than even generic Tobradex.
In Texas as well. And again, we're not just, looking at cost, obviously. We want to prescribe the best medication that's going to alleviate our patient's issue. But we also live in the real world. And unfortunately, I can't prescribe brand name Xylet or brand name Tobradex ST for everybody.
Joe, another question is, how long can a person continue on cyclosporin safely? And I think I think we can address that as either Cequa or Restasis.
Yeah, some patients need to be on cyclosporin pretty much for life. Again, I haven't run into tremendous safety issues with either one of those drugs. And I'll, if you guys don't mind, if you've had significant side effects, the worst, the worst thing I could see is, well, maybe it doesn't work as well as we would have liked it to, and then we need to change our strategy. But in terms of how long a patient can safely use it, pretty much as long as they need. Now, occasionally a patient, will be taken off and, just try to maintain on tear supplements or something like that. And we can sometimes do that because they want to get off of the medications. So that's a consideration as well. And then there's the pregnant patient. Again, if the patient has extremely dry eyes, is miserable, we have to weigh that, cost benefit ratio. But I wouldn't hesitate to prescribe it for a pregnant patient with punctal occlusion if they had severe dry eye disease.
Here's a question. I'm going to pose the question. It didn't come through the chat, but I wouldn't be surprised if people are thinking about this but haven't asked. And this is for you, Joe, and you too, Greg. And this is sort of how long a patient continue on cyclosporin. So how long can patients be on topical steroids? What is your record? How long have you gone a patient on topical steroids for severe eye disease?
Yeah, great question.
I have patients on chronically. They go through a DSEC procedure or a corneal transplant. So, we're managing those patients once they're turned over to us. So 1 drop a day forever for those conditions. So, I guess it depends on what you're treating, but, that condition, I would say, forever.
And my longest was 4 years, and that was a patient with a chronic relapsing iridocyclitis. So
I could think of one that I'm still treating, same condition, iridocyclitis and rheumatoid arthritis. I think for the better part of 2 years, she's been on topical steroid, and it's Pred Forte.
And I think it's important for us to mention that, because I know a lot of people are a bit shy about steroids, and they get a little bit worried about steroids, and they're at 2 weeks, people are starting to get a little nervous, and there are patients who we've had them on for years.
Absolutely.
Yeah, there's a judicious way to do it, and we know what to do if the IOP goes up. We're optometrists, we're clinicians. There are IOP lowering meds or maybe other steroids that we can go to. Looks like everybody got the dendrite question right, and the next one is about uveitis. Speaking of which. What statement, there we go, best describes the clinical features of uveitis. Really what I'm asking is, what is the uvea? So we know what a uveitis is. I'm expecting high 90s on this one.
The audience is not letting you down, Dr. Pizzimenti.
Throwing down the gauntlet here, right?
You're making it. And yeah, Michael weighed in here while the people is, Michael, you're 100% right, or Mike. Wouldn't it depend on the condition for the steroid? And the
Oh,
answer-
absolutely.
So,
Yeah.
so that was just the comment. All right.
And, of course, there's a steroid that is approved for ocular allergy, and it can be used chronically as well, right? Form of
All right.
prednisone.
Dr. Pizzimenti, you're not going to be let down here. I'm going to end the poll before it gets screwed up, though.
Well done.
So, all right, 97% for you. So,
the Twin Cities, Minneapolis, St. Paul, beautiful in the summertime. When I get a chance, I'm going to go there. Bacterial infection management. Here's an eye with some pus. This is a contact lens overwearer, a 19-year-old Hispanic female, habitually sleeps in the lenses, seen in our contact lens clinic. I wasn't working in contact lens that day, but somehow I ended up seeing the patient, and there it is, right? So again, not a trick case. We've got the large infiltrate with the overlying large epithelial defect. We see hypopion. We see some pretty good injection there, and there was white pus. So a purulent discharge, 20/80 acuity, pinhole no improvement. There's a bit of a close-up there. So, it's walking like a duck and sounding like a duck and all that. 3+ cell, corneal epithelial defect with a dense white infiltrate, the very definition of a corneal ulcer, right? This had a paracentral, really a central location. It had the indistinct borders in parts of the infiltrate and some surrounding edema. The mucopurulence, all of this suggests bacterial keratitis. Posterior segment is healthy. So this isn't a poll question, but just a self-test. Our differential diagnosis and what is the most likely out of all these: interstitial keratitis, bacterial, acanthamoeba, fungal, herpetic. Based on the information presented, this is bacterial keratitis until proven otherwise. So what is your plan? Treat or turf? And that may vary. If I'm in San Antonio and I have, cornea specialists that have all the blood agar and chocolate agar and culture media, central ones I'm typically getting same-day consultation or starting them empirically and getting next-day consultation. If I'm in, a rural area, I may have no choice but to go ahead and treat this patient empirically and follow them closely at first. And sometimes a cornea specialist is, several hours drive away, and you may go ahead and treat that judiciously as bacterial until proven otherwise. If you decide to treat, we remember there's a difference between bacteriostatic medications versus bactericidal. Bactericidal drugs kill the bacteria. Bacteriostatic drugs are effective in stopping the growth or replication of the bacteria. Sometimes in higher doses or more frequent doses, these drugs can be bactericidal as well. But treat to kill, all right? Don't mess around. If you decide you're going to treat this as infectious and bacterial until proven otherwise, which makes sense based on the history, be aggressive and treat to kill. So in choosing the proper drug therapy, we need to consider the efficacy of antibiosis. And so there are a couple of calculations or values that describe the efficacy. One of them is the MIC, or minimum inhibitory concentration. And this is the lowest concentration or dosage that inhibits visible growth. So the growth stopping concentration. The MIC measures the bacteriostatic activity of an antimicrobial agent. Then there is the minimum bactericidal concentration, or the MBC. And this is the lowest concentration of a drug that kills the microbe. And so we did end up getting a cornea consult the same day because we didn't have corneal scraping media at the clinic, and because of its central location. If it were maybe a little bit more mid to far peripheral, I would have had no issue. But it's fairly judicious to culture these when the center of the cornea is involved. So the scrapings were performed at the cornea office. The patient was actually started on Moxiza and Tobradex, so two different antibiotics in different classes. And I do like this strategy because it theoretically broadens the number of pathogens that are covered with your treatment.
Excuse me, Joey. You write Tobrex, but you said Tobradex.
I
wanna make
apologize.
Sure,
No, it's Tobrex.
yeah, so make
Yep.
sure people realize Tobradex would be a little bit aggressive at this time.
A little bit aggressive. Nope, there it is. Tobrex, tobramycin, without the steroid, at least on day one, right? Makes sense. So we broaden the spectrum of activity. Thanks for that correction. And scopolamine, we want to immobilize the iris. We want to preserve the blood aqueous barrier. So cycloplegia. Fortified antibiotic, that's certainly a consideration in a case like this, especially if you're in the middle of Nebraska and have to treat that central cornea ulcer. You're the only game within several hours, right? And daily follow-up. To nobody's surprise, the scrapings grew Pseudomonas. So in terms of bacterial infection management, and there's our Kimura spatula on top, and another case that wasn't mine, that I borrowed. Consider culturing an ulcer when there's an infiltrate greater than 2 millimeters in size with an overlying epithelial defect, if the location of the ulcer is central or paracentral. If there is significant tissue loss, the eye would benefit from culture. An ulcer with a concurrent hypopyon. If you suspect an unusual organism. If you go ahead and treat empirically, and we do expect some slight worsening maybe after the start of therapy if this ulcer has had a few days to fester. But if we don't get some stability after a few days, or it significantly worsens, then obviously we need to get that cultured. If the patient has undergone recent intraocular surgery, get a culture. What about steroids and bacterial keratitis? And this is the steroid that was used, I believe, in a study that I'm going to describe. So what does the evidence show, right? So this is the steroids for corneal ulcers trial, or the SCUT study. Overall, there was no significant benefit in adding a steroid, and I believe it was 48 hours after treatment with antibiotic. But there was one subset of patients, patients with severe Pseudomonas, where the addition of a steroid after 24 to 48 hours may improve the visual outcome. So in severe bacterial keratitis, especially Pseudomonas, you could consider adding the steroid after, say, 48 hours of aggressive antibiotic therapy with a fluoroquinolone, maybe in combination with an aminoglycoside like tobramycin, or fortified vancomycin. But not for nocardia. No steroid for nocardia if the culture grows the nocardia bacteria. Those eyes did not do well. They worsened with steroid. So avoid steroid if there is severe corneal thinning. if there's an enormous epithelial defect, if the patient has uncontrolled diabetes or is otherwise immunosuppressed. If you think in the back of your mind that, well, maybe this is acanthamoeba or fungal keratitis, or especially HSV, herpes simplex, the steroid should be avoided.
You know, Joey, in that Scott study, visually overall visually they didn't benefit, but out of those 500 people, the majority weren't like the ones that you just showed. They were mid-peripheral or marginal. You know, these were smaller ulcers, gram-positive, that were not in the visual axis. So steroids, no steroids, they're going to end up with the same acuity. So
Yeah.
I think that you and I both used steroids in the 90s on these things, and we saw patients get better faster. So
Yeah, and I still do after 48 hours, and some of these dense, already it's starting to scar type of situations. But I definitely want to get some aggressive antibiotic therapy before we add the steroid and prescribe them together.
somebody also, a question came in, what about polytrim with a fluoroquinolone? What do you think?
I think why not? I think that's certainly a good drug. Again, it's broad spectrum, and combining that with a fluoroquinolone, I think it could be just as effective.
And
Yeah.
there actually may be some benefit in patients who have a MRSA infection as well.
Right. That would probably be your topical antibiotic of choice. One of them, anyway. There's a couple of others. Maybe becifloxacin for suspected MRSA infection. Sure.
Actually, one of the best medicines for a MRSA infection is chloramphenicol.
Ah, going very old school and not available anymore in the United States, is it?
I think we can get it through some pharmacies, some compounding pharmacies. Everybody's worried about aplastic anemia, but I can tell you right now, in New Zealand and Australia, they laugh at us. It's over the counter. Any mother can walk into the drugstore, pick up a bottle of Chlorasig right off the shelf for their kid.
So they're using it. They're using it with impunity.
With everything.
And it works on MRSA.
There's a question or a comment about, can you just discuss a little bit on fortified and what that is and how that goes about?
Yeah, you typically the drug is vancomycin, but it could be done with any number of medications. A fortified antibiotic is done at a compounding pharmacy, and usually they can get that done within 24 hours. Now, you may have to start the patient on a fluoroquinolone, maybe in combination with a polytrim or an aminoglycoside. But in terms of efficacy, it probably has higher efficacy than any fluoroquinolone. And if you're dealing with a nasty central corneal ulcer, it is something that corneal specialists tend to favor. You could get fortified tobramycin. Fortified vancomycin is typically the one that's used for bacterial keratitis. It's not something that you're going to have the pharmacy prepare for a mid-peripheral ulcer that's only moderately painful with moderate symptoms. That's not something that you need fortified antibiotics for.
And just to kind of give that clue out there, or that little clinical pearl, those are compounding pharmacies. Those are not commercially available. And so my clinical pearl to the audience or to the attendees would be to already find out where you can get this fortified tobramycin, where you could get this Vanco, instead of when it walks in, you're going, oh, I listened to this great lecture by Dr. Pizzimenti. How do I find this?
Yeah.
Again, this is one of those, I like to know where Ziragan is. I like to know where 1% atropine is, and then and you need a compounding pharmacy who has those, and already the recipe is really the key on file so that they can make it for you.
Excellent tip. Yes. And pharmacists will work with you. It's good to form that relationship. Many of them are they're getting more and more clinical. And I think, so long as you let them know some of your favorites, they'll go the extra mile to have them on hand. In my case, it's atropine, and I like this prednisolone sodium phosphate and some other meds, and we have a couple of pharmacies that will do that. But especially when you do get that ugly central corneal ulcer, and you have to treat it for whatever reason, or at least start treatment, it's reassuring to have a compounding pharmacy that will have that vancomycin and be able to get it for you, get it made up for you. A little bit more on resistance. I'm going to kind of whip through this section a little bit. It's reading that you could do on your own, but I just wanted to mention antibiotic resistance because it is such a significant public health problem. And these resistant bacteria are becoming more and more difficult to treat, requiring other medications, alternative medications, or higher doses of existing antibiotics. And so just to give you some idea of the impact of antimicrobial resistance, we're glad to have antibiotics. They're sight-saving, they're life-saving. But resistance is becoming a worldwide issue. In the US alone, about 2 million people per year develop antimicrobial resistance. And 23,000 people in the US die annually as a result. The World Health Organization identified antimicrobial resistance as one of the biggest threats to global health, resulting in about 700,000 deaths per year. So again, we're talking about topical meds, but the big picture is we also prescribe oral meds, and even topical meds can result in resistance, right? So bacteria, parasites, viruses, microbes change to protect themselves from the effects of drugs that are designed to destroy them. So this is a natural phenomenon, right? It occurs in nature. These organisms adapt, and they're pretty smart. So previously effective antibiotics that we use to treat or prevent infection may no longer work. And there are many reasons that antimicrobial resistance exists, and many things, as you can see, that contribute to that. One of the big ones is overuse of drugs for minor infections or for prophylaxis. So how does it occur? Some bacteria are naturally resistant to a particular drug. The antibiotic kills bacteria, but not those that are resistant. And then the resistant bacteria now have more room to migrate and to multiply. And resistant bacteria can even transfer their resistance to other bacteria. What are the problem bacteria? Well, there's a lot of them. Antibiotic resistant bacteria cause infections with potentially serious consequences. The majority involve resistance to systemic antibiotics, which we also prescribe, but these are used primarily in the treatment of systemic infections. However, resistance to topical antibiotic medications is on the rise. Staphylococcus aureus, coagulus negative staphylococci, pneumoniae, Pseudomonas, Haemophilus influenza. These are all common causes of ocular bacterial infections. And of these, Staph aureus and this coagulus negative staph are frequently isolated, I should say, from eyes with infections, including endophthalmitis, as you can see, and then more minor types of infections. So those are a couple of biggies right there, Staph aureus and coagulus negative staph. Current antibiotic resistance threats in the US. So some of these organisms have a threat level of urgent, and they are Clostridium difficile and Carbapenem resistant Enterobacteriae. Another one is drug-resistant Neisseria gonorrhoeae. As you know, a sexually transmitted infection. Nowadays it's rare, but newborn gonococcal conjunctivitis was once a major cause of blindness in the United States. Common ocular surface pathogens, you're familiar with the staph epidermidis as well as the staph aureus, but regarding resistance, the most problematic is MRSA, which we've discussed in brief, methicillin-resistant Staphylococcus aureus. And then we've got strep pneumoniae, and this produces enzymes like streptokinase and hyaluronidase, allowing the microbe to penetrate tissue, leading to corneal perforation or orbital cellulitis. So these are the gram positives. The gram negatives include Haemophilus species and Pseudomonas. Neisseria as well. So as far as MRSA, MRSA can be fatal. All right, it's also very common in hospitals and other healthcare settings, nursing homes, dialysis centers, in which case it is known as healthcare associated or HA MRSA. Older adults and people who are immunocompromised are at high risk for this type of MRSA, along with healthcare professionals. So MRSA, the superbug. And you can see MRSA here on the cheek, MRSA just above the eye on the adnexa, and then conjunctivitis, keratoconjunctivitis. Over 80% of MRSA strains are resistant to all fluoroquinolones. And this is a class of drugs that we've been using as a mainstay for the past couple of decades. So this is a bit of a concern. And so some tips here: don't routinely prescribe antibiotics for acute mild to moderate sinusitis unless symptoms last for 7 or more days. Now this is pertinent because a good chunk of patients that we see in optometry that complain of headache or periocular pain have some sort of sinusitis. And the recommendation is that unless the symptoms last for 7 or more days, or they worsen after initial clinical improvement, to avoid antibiotics for those particular cases. Antibiotics should not be used for apparent viral illnesses. We know that. Don't prescribe antibiotics for adenoviral conjunctivitis, right? EKC. Of course, I put optometrist above ophthalmologist down here because certainly we are diagnosing these and treating these as well as ophthalmology. And then don't routinely prescribe antibiotics before or after intravitreal injections. They have virtually no effect in terms of patient safety. As long as povidone iodine is used and proper precautions are taken, intravitreal injections seldom result in endophthalmitis. And so 10 recommendations, I'll just highlight a few of them. Use antibiotics only when needed for bacteria. If you could precisely target, if you have a way of determining what the bug is, or at least predicting what the bug is, that's better than a shotgun therapy. Use the shortest antibiotic course that is effective. That usually means 7 to 10 days instead of the old, stay on this for 2 weeks, right? Which we used to do all the time because that's always how we did it. Well, now we know that most of these drugs can be prescribed at the proper dosage for 7 days. Encourage patient adherence. Let them know that we want them to get better soon, and we want them to use the course of the drug to its fullest. Use antibiotic combinations only in specific situations, such as Bactrim for MRSA, Bactrim being an oral combination drug, very effective against systemic MRSA. Avoid low quality and substandard drugs. Discourage self-prescription. My wife had a red eye, last month, and so I'm just going to use her medication. Try to follow evidence-based guidelines as best you can. And sometimes, the drug companies, they want to be helpful, but sometimes, some of the literature that they'll put out there as evidence-based could be inadvertently skewed. So look at real evidence, right? Rely on clinical microbiology labs when appropriate. Go ahead and prescribe antibiotics empirically when necessary, but do so intelligently with close follow-up. So some good recommendations there. I think this slide really says the same thing, right? And don't taper an antibiotic below its therapeutic dose. So as a profession of topical and systemic antibiotic drug prescribers, optometry has a responsibility to do our part to reduce the public health challenge of antimicrobial resistance. Time for a poll question. Which of the following is an ocular side effect of systemic steroids? Got conjunctival redness, posterior subcapsular cataract, corneal pigmentation, ocular itch. So this is systemic steroids affecting the eye.
You know, Joe, as we're waiting for people to roll in, there are a couple of comments that came in and a few questions. One, what do you think of a 5-minute loading dose for an hour on a nasty ulcer?
It will probably not hurt. You know, I've certainly done it. I haven't seen any controlled studies indicating that those patients fare better. It probably makes us fare better, and typically we have, you know, a preserved bottle of something potent in the office. But yeah, at least it lets us know and the patient know that we're getting a few drops in quickly just to get you started. I think it's probably a good idea. Are you aware of any studies that show that it definitely results in better outcomes? I don't know that I am.
No. I think, I mean, a lot of what we've done is particularly with Fortified, there were no studies behind it. It was just the philosophy, more must be better. The only studies that came out is when the fluoroquinolones came out, and they compared them to the gold standard of Fortified, and they showed that the fluoroquinolones were by and large as efficacious as Fortified, or one might say that Fortifieds were no better than
Yeah.
than fluoroquinolones. But up until then, a lot of this is personal recipes. 5 minutes for an hour, that's a lot. That's gonna kill a lot of stuff.
That's a lot of drugs.
I would probably do in office 1 drop every minute for 5 minutes.
Yeah, that'll be quick, and you'll still be loading the patient up. I think it's probably more important to set the installation schedule aggressively enough after that. It's really what happens when the patient leaves and gets their medicine. And again, to support the loading dose, it may take an hour or two for the patient to actually get their medicine. So, at least they have some drug in the eye. But we want to be aggressive, especially if we're dealing with a paracentral type of ulcer situation. So it's important, let's say, to prescribe that antibiotic on an hourly basis, maybe even some ointment overnight so the patient doesn't have to get up during the night. But loading doses, that I still do it. Again, I don't know if it helps, but I do it.
A few comments about Besavance has come through, mostly about the fact that it has no oral equivalent, so the risk of resistance is actually relatively low. Any comments on that? And also comments of gadafloxacin versus moxifloxacin.
Somebody read ahead. No, I'm just kidding. They probably knew it anyway. No doubt that, as far as the topical fluoroquinolones, becifloxacin does have that advantage of having no systemic counterpart, so it will be less likely to result in resistance. In terms of head-to-head studies, again, it's the newer generations of those two drugs. namely Moxiza and Zymaxid. I don't think I've seen a study comparing those two concentration-wise. We typically consider them to be clinically equivalent, but if you're really, really worried about a corneal ulcer, it's central or it's paracentral, I would still say get the fortified vancomycin and protect yourself. Remember, we're ODs and we are actually held to a higher standard than MDs. And, if a case goes south, and sometimes these do, despite our best efforts, sometimes there's scarring, sometimes there's bad outcomes despite our best efforts. It's good to be able to say, yeah, I treated aggressively with fortified vancomycin because it's a central ulcer, rather than, trying to determine between, well, should I use besifloxacin? Should I use moxifloxacin? Should I use gadifloxacin? Let's see, which of the following is an advantage of topical prostaglandin analogs? Again, skipping ahead to our glaucoma medications. Hopefully everyone.
So they nailed the posterior subcapsular cataract we were talking
Yeah,
about.
they sure did.
And
I
then
have a feeling they'll be nailing this.
they'll be nailing this. And while you're looking at that result, Vanessa sent me a text message. So Florida docs, I guess there's about 20 out there that don't have their cameras on. Please help out, Vanessa, please.
Yes, please help Vanessa. Show your face, right? Is that what we're trying to do?
Trying to stay compliant. So that's that. So
Are we up to date on questions?
Yes,
I think-
we are.
Move on.
Yep. So I'll stop the
This
sharing
is,
here.
Yeah, Florida does have beautiful beaches, I have to say. This one is outside of, on the East Coast, Northeast Coast.
Would that be Ponte Vedra?
That might be it, Joe. That might be it. Up around, what's that old city? St. Augustine?
Yes, it is.
All right, so battling infection, right? The fluoroquinolones, we've gotten very comfortable with these drugs. Of course, some of us remember when they first came on the market, and really it widened our ability and confidence in treating infectious keratitis and severe bacterial conjunctivitis. So these are potent bactericidal drugs, not bacteriostatic, with broad spectrum activity. And so they interfere with two enzymes that are needed for bacterial DNA synthesis. You can see on the right, those two enzymes are topoisomerase 4 and DNA gyrase. Thus, two separate mutations are needed for bacteria to develop resistance, but indeed they have developed resistance because, as I said, they're pretty smart. Moxifloxacin 0.5% is one such fourth generation agent commercially available as Moxiza, a newer generation of Vigamox with the xanthan gum vehicle, which will increase the ocular surface contact time. And it's approved for individuals 4 months of age and up for bacterial conjunctivitis, in which case it is dosed BID for 7 days. And I'll bet a lot of the 250 docs on this webinar have used this drug or another in its class for bacterial keratitis, especially mid-peripheral ulcers, because the drug is well suited for keratitis, even though it's used in an off-label manner in those cases, right? Also, Zymaxid, gadifloxacin, 0.5%, the newer generation of Zymar in a higher concentration, high efficacy, approved for those older than the age of 1 for bacterial conjunctivitis, also well suited for keratitis in an off-label manner. And then there's besifloxacin, 0.6% suspension, high efficacy, right? It's an ophthalmic suspension. It has an indication for bacterial conjunctivitis, including ocular MRSA and Pseudomonas. The Durasite vehicle, again, it's highly viscous and lengthens the ocular surface contact time. There is no systemic counterpart to besifloxacin, and so this reduces the likelihood of resistance. So this has really, I don't know if, I don't think it's on my current top 10 or 12, but it's knocking on the door. Probably I'm using this more and more, certainly. Topicals for ocular MRSA, the aforementioned Polytrim. Again, it's still around, it's inexpensive. Polymyxin B in combination with trimethoprim, eradication of MRSA conjunctivitis and keratitis. And then there are other drugs that have also demonstrated some efficacy against MRSA, including tobramycin, besifloxacin, and fortified vancomycin. All options for ocular MRSA. A systemic therapy for systemic MRSA is Bactrim, trimethoprim, and sulfamethoxazole. And this is a good broad spectrum antibiotic. Not only is it effective against MRSA, it's effective against a broad spectrum of microbes. So it can be used for preseptal cellulitis, dacryocystitis, internal hordeola, things of that nature. So as far as the main classes of topical antibacterial drugs, we've talked about the fluoroquinolones. The aminoglycosides, also broad spectrum coverage, slightly more effective against gram-negative bacteria as opposed to gram-positive. The polymyxin B combinations, also broad spectrum. The macrolide class of antibiotics, also broad spectrum, more bacteriostatic than bactericidal. So the macrolides are going to be bacteriostatic, so I'm not going to use those to treat, a central corneal ulcer when there are other more potent options. Bacitracin is still around, or it was gone and then it came back. This is a polypeptide ophthalmic ointment used commonly in anterior blepharitis due to staphylococcus and superficial ocular infections of the conjunctiva. It's good for kids and lids, right? Kiddos and lidos. So been around for forever. Probably the first drug I ever prescribed. Other antibiotic ointments out there. Again, nice to have these for overnight if you're dealing with a corneal ulcer, for instance, or a severe bacterial conjunctivitis. We've got Cipro ointment, and then we've got polymyxin B in combination with bacitracin. All right, then we're going to close it out with glaucoma. We've got about 10 minutes or so. But this is not a trick case. If you look real carefully, maybe you could see a little bit of a notch and perhaps some nerve fiber dropout, more apparent on the left eye than the right. There it is. Now here's our visual field showing a superior nasal step in the left eye. A few scattered defects, maybe an edge point or two on the right eye. And this was repeated and found to be consistent. Saw this case a long time ago with our older generation OCT, but we can see the inferior temporal retinal nerve fiber defect in the left eye, and then an area in the right eye superior temporally that we're watching. So topical pharmacotherapy is still a mainstay, even in the age of MIGS and MIPS, and I don't even know what else there are. There's all kinds of acronyms out there, right? These implants. Topical therapy is still a mainstay in the first-line treatment of patients with primary open-angle glaucoma and ocular hypertension. So it's nice to have the prostaglandins. It's especially nice to have the prostaglandins at $20 nowadays. These are lipid compounds derived enzymatically from fatty acids containing 20 carbon atoms, including this 5-carbon ring. And the prototype and first drug in that class was latanoprost. And so several of them out there now. Latanoprost was the first to come on the market, so therefore the first that lost its patent protection. And now you could get all three of these generically. For the most part, they work. You know, sometimes we have to insist on the brand in certain cases. But as you can see from this diagram, the mechanism is enhancement of outflow of aqueous via the uveoscleral channels. And depending on which studies you read, you know, we're talking about approximately 30% reduction on the average of IOP from baseline. You know, it's not an immediate acting drug, so maybe not your first choice for, say, an acute angle closure. The IOP reduction starts in about 3 hours, reaching its maximum effect after about 8 hours, 10 hours. Once a day dosing, of course, makes these such an attractive group of first line agents. You know, a newer generation prostaglandin that's been out for a few years now is tafluprost. I think this one is underprescribed because a lot of patients have ocular surface issues, and tafluprost is preservative free, comes in the unit doses. So this is a once a day preservative free prostaglandin. Comparable in its efficacy is tafluprost to the other more established prostaglandin analogs. And the side effects of prostaglandins are well documented in terms of darkening of iris color and, you know, longer lashes and so forth. And so, you know, we're all turning our offices into spas nowadays, right? It's amazing how this diagnosis of hypotrichosis, you know, this condition became so much more common after Latisse came on the market. Incredible. Epidemic. Prostaglandin contraindications, history of herpetic, you know, herpes simplex keratitis, active inflammation, uveitis. Those with an anterior chamber, we don't see this that often, anterior chamber IOLs may be better to go with a different medication or class of medication. Yeah, you know, let's do some polling, all right? A topical ophthalmic steroid that is FDA approved for the treatment of chronic allergic conjunctivitis is timolol, trifluridine, remexolone. There's an oldie but a goodie, still around. Lodiprednol etaborate, 0.2%.
Rolling in nicely here, Dr. Pizzimenti.
That's great.
I'll share the results here.
There it is. Very good. And yeah, you know, maybe it's, I don't think it's FDA approved, but remexolone 1%, it's kind of a light steroid, you know, it was sort of like a Lotemax before Lotemax. You know, certainly I could see using it, but Alrex was formulated specially for allergy. Another one, central serous chorioretinopathy can result from using which class of drugs? Beta blockers, corticosteroids, antihistamines, prostaglandin analogs. Central serous chorioretinopathy.
Our OCTs have certainly brought this to light.
Oh yeah, no question. It's more common than we think, and you know, could even lead to choroidal neovascularization. OCT and OCT angiography have enhanced our ability to detect it, even as a very subtle condition. Now, I've never seen central serous as a result of topical corticosteroids. I'm sure it could happen, but you know, periocular steroids, I've seen central serous, inhaled steroids, you know, for asthma, epidural lumbar injections for lower back pain. Corticosteroids by any route of administration can result in central serous chorioretinopathy, enhanced glucocorticoid activity, most likely at the level of the choroid. All right, some newer drugs here. A prostaglandin nitric oxide producer. This is latanoprostene bunode, 0.0224%, commercially available as Vyzulta. And after at least a decade, maybe longer, maybe a couple of decades of no new drugs for IOP lowering, Vyzulta and some of its cousins came on the market. This one has a dual outflow mechanism, increasing uveoscleral outflow as well as trabecular outflow through the activity of nitric oxide. Once a day dosing and excellent efficacy makes this an attractive first line treatment that I'm using a little bit more and more with the help of the company and its drug assistant programs. More information on this drug. The latanoprostene is broken down twice into its active components: latanoprost acid, nitric oxide. The nitric oxide helps to relax the contraction in the trabeculum, and this will increase outflow. And so side effects are going to be comparable with those of latanoprost alone, a little bit less perhaps periocular pigmentation, and maybe the lashes don't grow quite as long. Notarsadil ophthalmic solution, 0.02%, commercially available as Ropressa, is another newer IOP lowering agent that improves trabecular outflow through the activity of Rho kinase inhibition. It inhibits the activity of Rho kinase, so a ROCK inhibitor, if you will. Another once a day dosed drug, 25 to 30% IOP reduction in some of the clinical studies. Some more information: Rho kinase is widely expressed in the trabeculum. It promotes the assembly of actin fibers and regulates contraction. And so these ROCK inhibitors, therefore, are going to increase outflow by decreasing actin and myosin-driven cellular contraction. Now, they also reduce extracellular matrix proteins. So a multi-layered drug, right? It has inhibitory action against norepinephrine transporter. So it's a NET inhibitor, as well as a Rho kinase inhibitor. In addition, if that's not enough, notarsadil decreases episcleral venous pressure, providing multiple mechanisms for the reduction of IOP. Now, hyperemia has definitely been an issue, with my patients. And in some it's mild, in others it's more significant. In some it's transient and resolves. In others, we end up switching them. And so it's triple action, right? So we've got the Rho kinase inhibition, relaxing trabeculum, increasing the outflow there. The NET inhibition, reducing the production of fluid. And then the ROCK inhibition, again, lowering the episcleral venous pressure. Rocklatan is a fixed combination of notarsadil and latanoprost, once a day dose drug. So it's nice to have a combo drug that includes a prostaglandin. And in the clinical trials, this drug, commercially available as Rocklatan, outperforms either of the two drugs alone. Outflow pathways through the trabeculum and uveoscleral mechanisms. Now, I'd like to see a head-to-head study that compares Rocklatan with Vyzulta, and I wouldn't be surprised if somebody is working on that. Maybe Dr. Sauk is working on that, who knows. Aqueous production, so reducing episcleral venous pressure and increasing trabecular outflow. And you know what? I think we're pretty close. Rather than getting on a new tangent of topics, I'm going to fast forward. As I said, you've got, you know, a very comprehensive handout that's for a 3-hour lecture, but I like you to have it for reference. And we'll try to take maybe 1 or 2 questions, but first, let me summarize.
Joe, while you're moving forward there, a question rolled in, and I can
Yes.
weigh in, and then you can weigh in, and so can Dr. Salka. It says, does having the patient wipe off excess solution off the skin help with skin pigmentation with the prostaglandin analog drugs? And my answer is going to be yes. Is that, when you put this drug into someone's eye and they take the tissue and they're wiping it all over their face in a sense, and kind of from the upper eyelid or to the upper eyebrow or to the eyebrow down to the lower lid, you've seen them turn, and where the medication is can create a pigmentary change. So what we try to coach the patient is to put the drop in and kind of dab and not kind of smear the drug out. So that was a pretty good, thanks, Robert, for making that comment.
Yeah, it's a good observation. It does go back to proper installation, and it's not always easy. I mean, putting in my own, Sustain or whatever whatever drop I'm using for dryness, I'll overdo it and it runs down the cheek or hangs around my eye, and yeah, I think it bears paying attention to, getting it in the eye and wiping off the excess, dabbing it again. It couldn't hurt, and maybe it'll help avoid that issue. Has it been an issue with you, Joe, with your patients?
I've had a few people have periorbital darkening. Sometimes they don't really notice it, and I don't go looking for trouble.
Yeah.
I agree with Greg that just dab it dry, keep it off the skin, and I think it will help.
Yeah. All right. Effective pharmacotherapy depends on timely diagnosis. The ideal topical drug is potent, easy to dose, easy to administer, and cost effective with minimal side effects. And by staying current, we can better serve our patients as well as our profession. And so, as Uncle Ben from Spider-Man said, with great power comes great responsibility. So please prescribe wisely. And, if we have a time for a question, I'll take one. But otherwise, it's been a pleasure hanging out with you guys tonight and being with all of you folks. I see a lot of former students in there, some colleagues that I've known for years, and it's just good to be together. And one of these days, I'll see you in person.
Yeah,
Joey, I'm gonna go back a little bit. You made the comment about you want to see the study between Rocklatan and Vyzulta, and I don't think we're gonna see it, because in order to see it, you'd have to have somebody doing it who is totally independent, and that would probably mean low numbers and not much validity. You'd actually need one of the drug companies to come up, and you think about it. Who's going to take that chance?
Right.
Is Aerie going to do it and then find out, hey, Vyzulta won, and will Balch do it and find out, hey, Aerie won? So I don't think we're going to see that, Joe.
Yeah, probably not. But in the interim, we can prescribe these meds and become familiar with them, just like we did with prostaglandins before them and beta blockers before that, and some of the other drugs, carbonic anhydrase inhibitors and other combos. But I think it's nice to have these agents, these three new ones, and I think it bodes well, again, for optometrists to kind of take a leading role in IOP lowering. And again, ALT and SLT, they certainly have their roles, and we can debate primary therapy versus secondary therapy, and it's probably case by case, but topical meds are here to stay for optometry and glaucoma management and getting better. Well, that's great.
Yeah, Joe, nothing more than, great presentation. Thank you. Thanks, guys, all that,
Yeah.
thank you to the audience that's out there. So Joe, you hit the home run.
Thank you for having me, guys.
Dr. Saka, before I move into some housekeeping here, you have any comments? Or Joe Pizzimenti, any final comments?
Just goodbye and stay well.
My final comments. I thank you, Joe, for doing that lecture. I think everybody is happy to see you, or happy to see you again and hear you again. We don't have these opportunities. Interestingly, when we go to Mackinac Island, both Greg, Joe, and I are going to be doing lectures together, all three of us. So that will be a fun time that we're looking forward to, and I'm looking forward to spending some time with you. But we certainly thank you for spending your evening with us tonight. Thank you, Joe.
My pleasure.